Good evening, respected seniors and dear colleagues. It's my privilege to have a talk in front of IPR family. I would like to thank for the same in IPR and as well as Empower. So I'm not already everybody's tired. So I will go with the important topics in the form of clinical points in the management of hyperuricemia in nephrological perspective. So uric acid, as you know, is a product of nucleic acid. It's a mainly urine metabolism. And is mainly transferred to the blood. Is mainly 75% of the uric acid gets eliminated through the excreted through the kidney. Normally, as you know, female less than 6 milligram, male less than 7 milligram, child less than 5.5 milligram per day. Uric acid is an unknown uremic toxin. If you see under normal condition, uric acid value is maintained. Where there is either overproduction or under excretion is mainly was a hazardous for the uric acid. And the most common are manifested in form of gout, hemolysis, and presence of uric crystals in the urine system. It produces renal calculi, and because of chronic hyperuricemia and uric acid, recurrent uric acid stone, that may cause chronic uric acid nephropathy, gout nephropathy, then recurrent renal lithiasis, secondary hypertension. As you know, chronic uremia is chronic uric acid. Because of hyperuricemia, it can cause CKD progression. I'll just go through that in detail. Then recurrent urinary tract infection because of recurrent stone former and chronic renal failure. So there are causes of hyperuricemia, hereditary reasons. The second thing, under excretion, reduced excretion of the kidney. Then high intake of dietary urine in form of like non-veg food like chicken, then mutton, then high urines. Then drugs, mainly diuretics, as we know, diuretics, thiazide, loop diuretics, then salicylates, aspirin. There are the uricosuric drugs. Then fasting or rapid weight loss, they can temporarily elevate the uric acid level. So hyperuricemia with CKD, if there is a severe hyperuricemia more than 12, you need a pharmacological treatment. Moderate hyperuricemia, less than 12, more than 8. At that time, you require the pharmacological treatment. Then if it is mild, if patient is asymptomatic, you can wait, no need to take hyperuricemia. Then less than 6, no treatment, you just observe. And these are the mechanism. As we know, purine metabolites form uric acid. This hyperuricemia causes smooth muscle cell proliferation, vasoconstriction, then intrarenal RAS activation. Because of RAS activation, it can cause CKD progression, then COX-2 activation, endothelial dysfunction, cardiovascular disease, renal disease progression, and ultimately hypertension. And hypertension again causes tissue hyperxia, insulin resistance, and by that it can cause metabolic syndrome. So mechanism in form of renal phenotype, it causes RAS activation, then oxidative stress, mitochondrial dysfunction. By that it can cause arteriosclerosis, glomerular hypertension. Main mechanism for CKD is a glomerular hyperfiltration. And hyperfiltration injury leads to glomerular sclerosis, causes interstitial fibrosis, tubular atrophy. Then it can cause acute kidney injury by making uric acid crystals and cause tubular obstruction and causes AIN, which is good prognosis, it is reversible. And non-renal phenotype, as I mentioned, can cause metabolic syndrome, non-alcoholic fatty liver disease, diabetes, hypertension. Then hyperuricemia can contribute to the kidney damage. As we know, uric acid it causes endothelial dysfunction by reducing nitric oxide, then as an inflammatory marker, then oxidative stress and RAS activation. By this mechanism, it can cause atherosclerosis and reduce the GFR by increasing the renal vascular resistance. So these are the mechanisms how uric acid can contribute to kidney damage. It produces uric acid crystals. Then mainly uric acid crystals are made precipitated in the acidic urine. So in your patient having hyperuricemia, you can advise for the urinary alkalizer to make alkaline urine, alkaline pH more than 7 pH. So it will prevent the uric acid crystallization, then produce metabolic acidosis, then increase renal arterial resistance. As already mentioned, mainly glomerular sclerosis, and it can cause hypertension and reduce the GFR. Clinical significance because of increased uric acid, many manifest in the first metatarsus of phalangeal joint. It can cause mainly monosodium urate crystals and increase the catabolism of nucleic acid, and it leads to renal disease. Why it is to be done in assess the assessment report, monitor the patient with renal failure and see if the kidney stone may be high uric acid level. If you see in your practice there is a recurrent stone former. If any patient having 3 or more episodes of renal colic in a year, that called recurrent stone former. And those patients you can evaluate for what is the type of stone. So uric acid stone also you can come across. Those patients you need a required of hyperuricemia for medication for the uric acid in recurrent urine stone former. Monitor the if uric acid level too high. After some chemotherapy, patient who are on chemotherapy or radiation therapy, you have to monitor uric acid and see if medicine that decrease, as we know, drugs which can cause hyperuricemia. So the drugs, when patient is on drugs, you have to monitor uric acid level. Then hyperuricemia, if more than 7 in men and more than 6 milligram per dl in women, causes CKD, hypertension, atrial fibrillation, stroke, coronary artery disease, LDH, MI, heart failure, metabolic syndrome, type 2 diabetic. So these are the mainly important metabolic parameter. Then uric acid, they can contribute the ARF. We know that it can cause CKD. In how it reduces the ARF. So because of hyperuricemia, it causes a RAS activation, and by that increase renin-angiotensin system activation. So more and more aldosterone will develop. It can cause more sodium reabsorption in the proximal tubules, and more sodium reabsorption again it can cause hypertension. So this high blood pressure, and this high blood pressure again it causes renal damage by increase the renal arterial resistance. Then vascular smooth muscle proliferation, then renal calculi, then free oxidal mediated renal damage. So these all can cause renal damage and cause acute kidney injury, which is reversible. If you control the uric acid, it can reduce your AKI. Then serum uric acid is an independent risk factor of the acute onset of renal disease, new onset of renal disease. Again, in your diabetic patient having high creatinine, CKD, if you monitor uric acid, uric acid also can is an independent marker for the development of nephropathy, diabetic nephropathy in diabetic population. Mainly type 1 diabetes. Type 1 diabetic patient having more progressive CKD at early onset. So is uric acid also the marker for metabolic derangement. And general dietary guidelines, the high protein diet is associated with increased uric acid excretion. So in your recurrent stone former patient, you should advise low protein diet. Then second, urine-rich vegetables, like you can avoid urine-rich vegetables. Vitamin C, 500 milligram per day has mild urine lowering effects. Then high fructose corn syrup. If you know in this fast food and all like artificial sweetener, they are using high fructose corn syrup. So that will also increase your blood urate level, and hence is not recommended. Coffee may decrease the risk of gouty attacks. Coffee can reduce the uric acid. Alcohol again increase the urate level by increasing the uric acid production as well as impairing the excretion. In alcohol again, beer with its high purine content. Beer having high purine content as compared to wine. So they have more elevation of uric acid level. Then these are the recommendations. You should reduce the weight, limit red meat intake, fish intake, because they need more omega-3 fatty acids. Then drink skim milk or consume low-fat dairy products. Then consume vegetable protein, nuts. Reduce alcohol intake. Limit the intake of sugar sweetener, and then limit intake of food they contain high fructose corn syrup. And diet sufficient with vitamin C, fruits, and coffee intake. Then what is the role of urate lowering therapy in prevention of CKD? As you know, allopurinol and fexostate, they will mainly as a urate lowering therapy. In the fexostate, there is no dose modification required. Even though in CKD patients like less than 30 GFR, you can use full dose of fexostate. While in allopurinol, you require dose modification. If your patient is GFR more than 30 ml, you can go with 100 milligram twice daily. But if GFR is less than 30 ml, then you have to reduce your allopurinol dose, 50 milligrams per day. Colchicine. Usually colchicine is a nephrotoxic again. In your patient of GFR, if GFR is less than 30, then dose adjustment is not required. You can use full dose. If GFR is less than 30 ml, then you should titrate your colchicine dose 0.5 milligram once daily. Then again NSAIDs, no NSAIDs because again less than 30 is contraindicated. Then for steroids you can use, there is no dose limitation, only provided you need to check renal function. Then SCTS, no dose adjustment. Interleukin 1 inhibitor, these are the inactive. Less than 30 ml, there is mean plasma clearance is more declined by 70-75%. So you need to consider dose reduction. Then uricosuric agents, most commonly allopurinol is analog. As we know, these are allopurinol. It can reduce the uric acid level. Then precautions with uricosuric drugs. If you are patient, you are put on the uricosuric drug, you have to tell your patient drink plenty of water, and target urine output is around 2 liters per day. And to prevent the precipitation of uric acid crystalline urine tract, this can further prevent, as I mentioned, you have to use alkaline agent in form of potassium citrate, 30 to 80 milliequivalent per day, to maintain urine pH above 6. Uricosuric drugs are to be avoided in a patient with history of recurrent uric acid nephrolithiasis. And aspirin, again I mentioned, is a uricosuric agent. So dose more than 3 gram, usually having more uricosuric acid effects. And avoidance, as we know, thiazide and loop diuretics, again it inhibits the renal excretion of uric acid. By that it can avoid it in a patient with gout. Then as low dose is aspirin, again aggravate hyperuricemia. So these are the food low fat diet, cherry, dark berries, then vegetables you should do. You have to avoid red meat, then fish food and liver. Then alcohol, seafood you have to avoid, and non-veg food having high uric acid. So now we have patient having serum uric acid 7, 8 in your day-to-day practice. So which patient you should start uricosuric drug, or you should give treatment for hyperuricemia, because in every patient uric acid reduction is not required. So indication of prophylactic treatment in hyperuricemia, if your patient having extensive cell lysis and chemolysis, patient who are on chemotherapy or radiotherapy, chemolysis, who are having more tumor load, then patient having history of gouty flare, recurrent flare is again indication. Moderate impairment of renal function, like is less than 30 ml GFR, you should consider. Then patient prone to have recurrent attacks of gout. Then asymptomatic familial hyperuricemia, you can use. Patient with recurrent uric acid stone, evidence of tophi and ultrasound. Then chronic gouty arthritis, binge alcoholics. Then patient with severe hyperuricemia more than 12 in male and more than 10 in female. Uric acid excretion more than 1 gram in 24 hours. Again, it's an indication to start prophylactic uric acid treatment, because in your patient having recurrent uric acid stone, you should advise 24-hour urine collection. In 24-hour urine collection, if uric acid more than 1 gram, it is a candidate to give prophylactic management for uric acid. KDIGO 2024 guidelines, kidney disease initiative global outcome 24, they suggest not using agents to lower serum uric acid in people with CKD and asymptomatic hyperuricemia to delay the CKD progression. If your patient is CKD, if serum uric acid is 8, 9, so according to KDIGO guidelines, not to use any medication for hyperuricemia if patient is asymptomatic. So there is no any proven role for CKD progression. It can't retard the progression. But when to start treatment? Treatment indicated if your patient is in symptomatic hyperuricemia or gout. After first gout episodes, especially uric acid more than 9 mg per dl, presence of tophi or radiographic damage, and recurrent uric acid kidney stone, they are the patients who you need to treat. I summarize: hyperuricemia, elevated serum uric acid more than 6 in women, more than 7 in men, and elevated again is day by day because of our lifestyle and Western diet. The high uric acid level. Most people, they are not having clinical manifestation. Most of the patients are asymptomatic. And then long-term hyperuricemia can cause metabolic de-enhancement in form of cardiovascular, diabetes, and overall morbidity. Hyperuricemia results either from the increased production or decreased excretion or combination of both. Most people of hyperuricemia are asymptomatic. Around 85 to 90% are asymptomatic. But elevated uric acid in blood or urine can lead to gout or nephrolithiasis. Thank you.